opportunity for our virtual clinical town hall forum on COVID-19. My name is Nicky Fantides. I'm blessed to serve as the Chief Medical Officer of the county, and I'm very thankful for this collaboration that we have tonight between the Medical Society of San Diego, the Hospital Association of San Diego, and Imperial County, and the County of San Diego as well. What I'd like to do is, after the welcome, is just fill you in on a few instructions and some feedback and some thoughts to consider to make the next 90 minutes valuable. We're going to kind of rearrange things a little bit tonight in order to accommodate some schedules, but right from the get-go, I wanted to make sure that all of you as participants are aware of a couple opportunities and behind-the-scenes things that we want to do to be able to accommodate good discussion and resource sharing. We obviously are looking for this to be a time of community and a time for us to come together and share lessons learned and resources that are available. A lot of that will happen virtually by discussion, but we do have the chat function. The chat function is there. You may make commentary. You may ask questions of each other. There is also likely going to be a fair amount of resources that are posted on the chat. Those will be included in the follow-up emails that we send after this evening. The other important function to be aware of is the Q&A function. And obviously we have some things to share that are prepared, but we also want to have the opportunity to be responsive and have dialogue, and all of the panelists tonight are here for that purpose, and we look forward to saving a meaningful amount of our time for that interactive function. The other thing I want to share up front to just be mindful of is that unlike the first version of these town halls that we did back in March till middle of June, we went through the extra step of requiring a registration, and it was much more of a quote unquote secure environment. We decided to minimize the logistic barriers, and so we did not require registration this time. But still, please, a reminder, this is a clinician, if you would, safe harbor, and designed to be a forum for us to have open dialogue. But please be mindful that it is something that we are not having airtight control over, and so certainly, though not intended as such, the links and so forth could be forwarded, and so nobody's hiding anything from anybody, but we're trying to thread the needle between having authentic clinician intimate discussion, realizing at the same time that it could be something that makes it out to the general public. So with that, what I'd like to do is at this point, because we have several new participants, but at this point I'd like to introduce our first presenter, and because of a schedule consideration, we're going to start with him, and I want to make sure to let you know that if you have questions specific to this topic, to start getting those in now, and then Dr. Jim Schultz, who's well known to all of us, will mediate the Q&A portion specific to this, and then after that we will do the rest of our panelists and move on to the rest of the program. Our first guest is a good friend and a very good collaborator regionally and at UCSD, and that is Chris Longhurst. And Chris, I would love to now turn the virtual camera and mic over to you, and you can give a little bit more background on yourself and share a little bit about the exciting developments related to California Notify. Thank you.
Terrific. Well, thank you, Dr. Nick, and hello to everybody out there in the ether. I'm really delighted to be able to speak with you this evening about CA Notify, which is the app that you've hopefully heard about to help slow the spread of this virus. I'm a practicing physician at UC San Diego, where I see newborns in our newborn nursery. And I also serve as the Associate Chief Medical Officer and Chief Information Officer, where I get the pleasure of working for Patty Mason. So I'm going to tell you a little bit about this system, which has been piloted at UC San Diego since late September. We actually started it with our student move-in on campus. Statewide expansion was announced 2 weeks ago at the governor's press conference on December 7th, and it became available statewide that Thursday, December 10th. And UC San Diego Health, because of our 3 or 4 month history partnering with the state, is actually under contract with CDPH to provide support for this, which we do through infrastructure, project management. We actually are running the call center for the state, and then we do education like this outreach tonight. So really, again, appreciate that opportunity. The take-home point this evening is please turn this on if you haven't already, and ask your family and friends to do the same. And so I want to tell you a little bit about how it works, and I'll share with you what we learned piloting this both at UC San Diego with our students as well as in the health system. So this exposure notification system, first of all, is completely private. And we know that's one of the most common questions that comes up. Does this track my location? It does not. In fact, no identifiable information ever leaves your device. It's really innovative the way that this is put together. It was announced by Apple and Google in April, became available in May. And the way that it works, you can see here, two people who don't know each other. It could be Bob and Alice on a park bench, or it could be 2 college students who were unfortunately unmasked at a get-together. But they both have CA Notify on their smartphones. Maybe one has an iPhone, one has an Android. And they spend 15 minutes within 6 feet of each other, so CDC criteria. And in fact, it's the latest CDC criteria. It's a cumulative 15 minutes. So they might spend 5 minutes in close contact for 3 days in a row, and that counts as an exposure. Because they're in that close proximity, their phones exchange anonymous keys, cannot be traced back to anybody's device. But it's the same idea if you've ever been on a bus or a plane and you turn on your Bluetooth looking for a headset and you see all the other devices nearby. That's essentially what's being used, those radio waves. And again, remember, it does not collect your name, any identifiable information, or location. So a few days later, Alice unfortunately tests positive for COVID. Her test result is reported to CDPH, regardless of where she got that testing, at San Diego County, at Scripps, Rady, Sharp, UCSD, or elsewhere. And so then she decides voluntarily to enter a validation code that's given to her by text message from CDPH. And that launches the anonymous exposure notification. And therefore, within a 4 to 6 hour time frame, Bob and anybody else that she's been in close proximity with would receive that alert. And the alert directs them to a website with CDPH approved information about, quarantining and testing and that sort of thing. So that's essentially how the system works. And I want to share some findings from our pilot at UC San Diego. And the first thing I think is really important, particularly for this audience, is that we did focus groups with our patients, with our employees, and with our students, and we learned that people viewed this as a health tool. Now, it is not a silver bullet, but it's clearly part of a larger pandemic defense effort. So I love this graphic that is at the bottom, the Swiss cheese model. Our pandemic defense is multiple layers of the Swiss cheese, right? And it starts with wearing a face mask and physically distancing and hand washing, but it also includes regular symptom screening. Depending on where you're employed, it could be regular asymptomatic testing and adding CA Notify to your phone. So, people ask, well, what's the outcome? The answer is it's actually really hard to measure because it's so private, we couldn't get that data back. However, we saw very low rates of COVID over the last 10 weeks in our students and employees. And we believe that this helped because we have a number of stories of times that this notified students or employees earlier than they would have through traditional contact tracing, or in some cases, they wouldn't have been notified at all. And so that gives us the confidence the system's working. It's also been extraordinarily private. Number two, the efficacy in limiting the spread is going to be proportional to adoption. So the more people that use it, the better. And so we're really looking for maximal adoption. Because San Diego started early, we think there's probably higher levels of adoption in San Diego than some other parts of the state. But let's do this. Let's get it higher. And one of the things that we know that helps is messaging from healthcare providers. I spoke last week with the CEOs of the different health systems at a HASDEC meeting, and we'd really love to see other health systems do what UC San Diego Health did, which is to send text messages to our employees. Why text messages? Because in our measurement and our user groups, it was clear that more people click on text message links on their phones than they did on emails and other kind of conventional advertising. So we actually had a long discussion at UCSD about whether we were going to use our emergency broadcast system. We ended up using it, and we know that drove a lot of traffic to our website during the pilot period. And then finally, these validation codes for people to launch anonymous exposure notifications, they can only be distributed currently by CDPH or our testing center line. We're looking at options for other health systems to be able to distribute that, and even physicians to be able to distribute those directly when people test positive, which, as we see more and more home testing and rapid tests and things, may be really important. But the important thing here is that distributing these codes as close as possible to the time somebody's diagnosed maximizes the clinical utility, right? The more upstream it is, the more proximal it is to the diagnosis, the more likely those exposure notifications are going to make a difference in slowing the spread. So every state before California, there were 18 of them that had already rolled this out. We're number 19. And every other state had not distributed these validation codes in an automated fashion. They were using their case investigators as part of contact tracing. And we speculate that that may be part of the reason that we haven't seen terrific outcomes in other states yet, because it was really further downstream. And so in the time between when our pilot completed and the state went live, Colorado actually started texting this to every single person who's positive. California took the same approach. I can tell you just today, 4,000 or 5,000 people have already entered these validation codes for anonymous exposure notification. So we're optimistic about this, but continue to work on it. So what can you do? Just please encourage your patients to enable this if they've got questions. I want to actually take you through really quickly what this looks like. We'll put this in the chat, but the website is canotify.ca.gov. And the website has really clear instructions on how to sign up on an Android or an Apple device. Here's the website. So you can see how does it work, very privacy preserving, how does this help, and then adding your iPhone. So it used to require iOS 13.7 or later. You just go into settings and you turn on the exposure notifications for California. No app to download, it's built into the operating system. Just this week, they ported this back to iOS 12.5 so that older iPhones, the type of iPhones that seniors might use, would be compatible as well. So it's really exciting that they've actually updated an older version so that I think all the way back to iPhone 6 and even 5S this works. So 6 or 7 years of phones. And then on the Android devices, you can get it on the Google Play Store as it's listed here. Notice on that webpage is the help desk number. This is open 7 days a week and it's 8 to 6. There's a bunch of frequently asked questions. And then you can see this is powered by my team at UC San Diego Health, along with the California Department of Public Health and California Department of Technology. So that's the main message. I'll stop there. And it looked like there were some questions coming through the Q&A.
Thank you, Chris, so very much. Jim, I'll turn it over to you. And I have a couple questions of my own.
Great, thank you. So one clarification, is this an app or a setting on your phone?
Yes.
We keep hearing about an app, and people are looking for an app in the App Store.
Yeah, it's called an exposure notification system because it's both. So on the iPhone, it's just a setting built into your operating system, makes it really easy to turn on. On the Android, it is an app that you download. So okay. The answer is yes, it's both.
Thank you. Does it work with the Apple Watch?
It does not work on the Apple Watch today.
Okay, very good. And what are people supposed to do if they get a notification?
The notification provides some pretty clear directions, some verbiage approved by our colleagues at California Department of Public Health that says, essentially you may have been exposed on this date. And while that doesn't give you the insight into where and when it may have happened, it does allow you to reflect, was I in a, masked PPE situation or an unmasked gathering, that sort of thing. And then it drives people to a website on the CA Notify site that has quarantine information approved by CDPH and, some next steps in terms of contacting your physician.
Great, thank you. What type of positive test are you wanting to be entered? Do you want a rapid antigen test? Do you want an antibody positive test result entered?
Yeah, it's certainly not for antibodies, right? It's not for somebody who's had past infection. This is for somebody who has a current active infection. And so PCR tests are the most common, but as the rapid antigens become more prevalent, we may see more of those, which again, Dr. McDonald and I have talked about is another possible reason to decentralize this code distribution. So it's not just all the positive results that have been electronically reported to the state, but perhaps some of these newer modalities as well. And I'm very eager to get this decentralized and allow our colleagues at other health systems and even physicians to roll these out, but we're working closely with the state on that.
And so some of the doctors are doing the rapid antigen test in their office. Would you like to see them have their patients download the app or activate the notification and report that immediately in real time?
Yeah, so remember the exposure notification system only works if you've got it running all the time and it's capturing those interactions, right? So turning it on at the time that you're testing is not really as helpful. And that's again why anybody who can out there, I'd really encourage you, if you're messaging your patients about how to stay safe over the holidays, things of that nature, please include some information about going to the canotify.ca.gov website and enrolling in this app. Because at the point that you get the positive result, it's too late to turn it on.
Very good. One last question that I have is, so folks that are working with COVID patients a lot, are we going to get notified like constantly?
Great question. That has not been our experience at the health system.
Okay.
So first of all, again, if you realize how the system works, it's really retrospective or retroactive. At the point that you've triggered it, you're no longer going to trigger exposure notifications because the assumption is once you're positive, you're now isolated, right? So none of our inpatient, hospital medicine folks, et cetera, are seeing that. It is feasible, I guess, that could happen in the emergency department. But I see Dr. Berger there, mentioning I've had it on my phone for weeks. I've tested patients in the parking lot, have been positive, but I'm not getting notifications. Again, you got to meet that CDC criteria, which 15 minutes within 6 feet is actually quite significant, and so it's tuned to really decrease those false positives. I also want to acknowledge Dr. Duck from North County Family Medical Group says it took 10 seconds to turn on the settings of the iPhone. That is accurate, and I can attest to that. Dr. Scheinberg mentioning houses of worship, that would be a great place to put it up. And another comment here about the PDF, there is a flyer that you can get put up in your offices and elsewhere. It's on the bottom of that website under the media kit. There's a PDF that you can print out. And Dr. Nick, semaybe we can get a copy of that and distribute it as well.
Absolutely. Anything else, Jim?
One more from Sean Berger is he's been doing a lot of testing, and he would think that he would have been notified from some of his patients. The question is, maybe the patients haven't activated this or downloaded the app, or maybe does he have to have his phone in his pocket at the time? Those are the questions.
Yeah, again, the way that this works is that your smartphone device has to be in close proximity to somebody else's for that 15-minute time period and within 6 feet. So I can tell you that some even masked meetings I've been at, I've seen staff, I'll put their phones in the middle of the table to make sure that they're exchanging Bluetooth keys. So tell your family and friends, tell your patients. We'll get that PDF out, put it up in your offices. Let's make San Diego really the leader in terms of this exposure notification. And again, I want to say thank you, Dr. Yang, San Diego County Medical Society, and Dr. Nick and Dr. McDonald, the San Diego County Public Health, for the opportunity to share tonight.
Thank you, Chris. I'm not going to let you go just quickly yet. I have two quick other follow-ups and then one comment myself before you head out. Number one, you mentioned the whole issue of the privacy, obviously, but also that somebody, once they get their positive test result, comes with a exposure notification. Do we even have the data on the percentage of folks who are positive that quote unquote launch the notification? Do we even have that kind of data?
Yeah, that's a great question, Dr. Nick. So we don't have data about who's launching these. We don't have data about who's receiving these. The latest version actually allows some opt-in analytics when you turn on that will be anonymous, but we haven't even gotten access to that at a state level yet. The one thing we do know is when we're distributing these keys, if they've been entered. So we don't know by whom or where or anything like that. We entered over 50 keys for positive individuals, employees and students at UC San Diego during the course of our pilot. And we got some people testing who told us that they were testing because they got anonymous exposure notifications. And so that's how we have some of these stories, is because of our testing line. What we can tell you now, I think everybody's heard that yesterday was a record day. I think over 50,000 positive cases. We're texting all of them with a link to voluntarily launch exposure notification. And I'm eager to see today's data, but because it's a day delayed. But I can tell you just yesterday that we had, I think, over 5,000 or 6,000 keys that were actually entered to launch these exposure notifications. So we're optimistic. Lindsay Winkley did a great story in San Diego Union Tribune yesterday. We gave her as much data as we could scrape together. And it looks like we're going to beat any previous state, not just in terms of numbers, which we would expect because we're so large, but in terms of percentage of the population, adopting this. And that's really what it takes for this to be effective.
One more question and then a comment by me before you leave, Chris. I troll all kinds of media and I have all kinds of friends. And I have gotten a consistent barrage of concern again about the privacy. And this is now the big state tool. After the pandemic is over, I'm still going to get tracked or whatever. For the clinicians that are listening at the moment, what is your 30-second elevator, if you would, response to those ongoing concerns that constantly keep coming up?
Absolutely. The first thing to know is it's voluntary. It's opt-in. So if you really are opposed to it, you don't have to do it. The second thing to know is that it does not collect location data, and there is no identifiable information leaving the device. And how do we know that? Because Apple and Google told us, but also because we tested it in my shop. And we absolutely know that that's the case. And so I feel very comfortable saying that. And that was part of the reason the University of California partnered with the state of California, was to test out some of these claims that are coming. Number three, if you're a privacy advocate, you know that one of the groups that does the most advocacy in that space is the Electronic Frontier Foundation. EFF actually just recently, related to the California Go Live, did endorse these systems, said these are privacy preserving systems, and they're meeting our threshold for privacy in terms of the anonymous nature. Nobody can know this. But again, you can say all of that, Dr. Nick, but people are still nervous, particularly when they hear from their employer. And that was one of the things we found in our pilot, was that when we as an employer told our employees to do this, there was suspicion. But when we as a health system suggested this to our patients said, hey, we trust our doctor and our doctor's offices with the most private details, and we trust that this is a health tool that's going to help us. So if we can get Kaiser, Scripps, Sutter, everybody out there advertising it, it's going to be a real game changer.
Thank you, Chris. And absolutely, that's something we've experienced with other issues, the contrast between when it comes from an employer versus it's a regional effort and the tide that rises all, right? There's that built-in privacy concern. Just because there's a tie-in to this clinical town hall, I want to just acknowledge, I still remember like it was yesterday, when we first discussed this was right after an in-person clinical town hall in the late of the night, you, Eric, and I had the privilege of being part of the discussions with Google and Apple early on when we were thinking, oh, let's just do it on a regional basis. It had to work its way through the state and all of that stuff. The thing that I want to emphasize, in not just my personal appreciation to you and to all of your team that advocated for this, we've taken a lot of pride at being at the tip of the spear here as a region. But as we will be discussing, and as everybody's aware, based on just the number of cases that our own department under the leadership of Dr. Wooten and Dr. McDonald, we need all the tools in the chest right now. The contact tracing efficiency, even though we have hired hundreds and thrown millions of dollars at resources to do the traditional way, is still tough for us to keep up. And so having both this partnership, knowing that this initiated here in San Diego, we've been supportive and deeply grateful to you and your team, Chris. So thanks for making the time tonight, and I'll let you say a final goodbye and then enjoy the rest of your evening and your commitment.
Yeah, terrific. Thank you for having me. And again, we're all in this together. And so I really appreciate the opportunity to collaborate with everybody across all the health systems and doctors' offices, whatever we can do to help. And if there's anything we can do to support you on the CA Notify app, please feel free to reach out directly to me. I'll put my email address in there as well.
Thank you, Chris. Really appreciate your time and taking the time to join us tonight. Thank you very, very much. And thank you. Thanks, brother, and congrats. All right, everybody, we're still here. We did a little bit of an unusual thing just because Dr. Longhurst had a limited time window that he could be with us. I'd like to welcome you all that have joined since the introduction and just quickly do a couple things and a couple clarifications. Again, we're going to transition our time now to getting a presentation that I think you're going to find timely and informative. Tonight, we are going to attempt to focus on the issues of vaccination and monoclonal antibodies. Based on what has occurred, frankly, even over the course of, hold on, if you can keep yourself, I don't know who that was on mute. Based on the course of what's occurred over the course of the past few days, there's a lot of issues that are emerging related to ICU capacity, ambulance diversions and things like that. And if we have time, perhaps we will try to maybe answer some of those, but we've committed to kind of having a little bit of a thematic flavor. And so tonight's prioritization is going to be on vaccination and monoclonal antibodies. And we promise we will do our best. Dr. Jim Schultz, who I'll have him introduce himself with a little bit more background in a moment, is our guru of Q&A. He will answer what he can in the chat forum. And we will use your questions to potentially guide future topics. So please keep that in mind and feel free to ask questions about anything related to COVID that you'd like. But we're going to try to do our best to prioritize and have a thematic approach this evening. Before we have our presentation, I would like to take the opportunity to have all of tonight's panelists introduce themselves and a little bit about themselves and their background and sort of where they fit into the COVID puzzle. And we'll quickly go around and do that with all the active participants. And then from there, we will have our presentation and then transition to Q&A. First, I'd like to ask and invite Dr. Susan Little, please, to introduce herself.
Hi, everyone. I am an infectious diseases physician at UCSD. In my, as I like to say, previous life, I was an HIV research physician. And like many other people, I have pivoted to COVID research and am currently leading 2 of the COVID vaccine clinical trials and working with UCSD on the allocation and distribution plan for our healthcare system.
Thank you so much, Susan, and thanks for making the time to join us tonight. Next, though by no means new to the clinical town hall, but for our first time in the virtual platform, I'd like Dr. Wilma Wooten to introduce herself, please.
Thank you, Dr. Nick. Good afternoon, evening, everyone. My name is Dr. Wilma Wooten. I'm the Health Officer and Director for Public Health Services and have been with the county since, officially since October 2001, and Health Officer since 2007 during the month of February. So thank you. Glad to be back.
Thank you, Dr. Wooten. Thank you. Next, I'd like to introduce another first-time participant, Dr. Rodney Hood.
Good evening, everybody. Thank you, Dr. Nick. My name is Rodney Hood. Many of you may know me for being in private practice here in San Diego as internal medicine for the past 40 years. I'm happy to say about 7 months ago, I've integrated my practice and now I'm medical director at CareView Health with San Ysidro. Why am I here? Well, in the past several months, I've been very involved in the COVID war that we have going on in our country. I am part of a national COVID task force with the National Medical Association. I have been appointed to the governor's California Science Safety Review, Vaccine Review, making recommendations for California. And locally, I'm one of the tri-chairs for the San Diego County Vaccine Clinical Group, making recommendations about distribution here in the county. Thank you.
Thank you so much, Rodney, for making the time. Next, I'd like to introduce one of my county colleagues joining us for the first time tonight, Mr. Rob Sills.
Good evening, all. Great to be here. Rob Sills. I have been in the county employment for about 10 months, and then the pandemic hit, so I was under pressure to get my 1-year tenure in. But prior to that, about 20 years in the healthcare environment, acute care setting. For the last probably 10 years, it's been in healthcare administration and emergency management. And my current role is I'm the director of the Medical Operations Center. And the Medical Operations Center, or the MOC, what we do is we're kind of the air traffic controller for all medical operations, whether someone needs resources, whether it's an item, N95, or staff. You know, we reach out within the region and then up to the state through the MOOC, which is a Medical Health Operational Area Coordinator process. So I am the MOOC for San Diego County, and those decisions and those resources will come through my office, and that's, I think, why Dr. Nick, thank you for inviting me and be able to talk about these antibiotic therapeutics that we're going to be talking about. And I'll try to pronounce the names, but please forgive me because there's a lot of letters in those syllables. Thank you.
Thank you. Thank you, Rob, very much. And if there ever was and I'm saying this as a friend to bust his chops a little bit, but he's been the COVID Santa Claus. He's the air traffic control on a lot of the logistics. Obviously, he has a tremendous team supporting him, but there's questions that may come up related to logistics and, you know, allocations and all those kind of operational things. So thank you, Rob. And for tonight, you're our honorary clinician, Dr. Rob Sills, all right? I would like next to have him introduce himself, Dr. Christian Raymer.
Good evening. Thanks, Dr. Nick. It's nice to be back. Christian Raymer's infectious disease and addiction medicine, med-peds, UCSD School of Medicine alum. And I'm here at Family Health Centers as one of the assistant medical directors. Also pivoted to doing a whole lot of COVID these days. I facilitate a Latin American ECHO project that's all about discussing COVID, as well as a national U.S. government mini-series on monoclonal antibodies through Project ECHO and Operation Warp Speed.
Thank you, Christian, and thanks for coming back. And even though he was not listed, quote unquote, on the agenda formally, I would like to also have Dr. Eric McDonald, who is quote unquote virtually and literally up my sleeve as my go-to when I fumble publicly. Eric, if you could introduce yourself, please.
Good evening. I'm Eric McDonald. I'm the medical director for the epidemiology and immunization services branch for the public health services, and I've been with the county just over 10 years, and I'm happy to be contributing as I can here to this effort. I've was just on the news conference with Dr. Wooten, and there's a little bit of everything going on, whether it's emergency medical services, whether it's the second highest number of cases reported. Actually, in the last 2 days, we've had over 50 deaths in San Diego announced to the public. A lot going on. Just happy to back clean up and just answer questions in chat as necessary.
Thank you so much for making the time. And one other individual that I want to introduce and have her give a little background, because she really is responsible for prompting us to reinitiate this, and also is helping, and already see her posting feverishly resources for you, is Dr. Holly Yang, our San Diego County Medical Society president.
Thanks all for being here. I'm just grateful for this incredible group of expertise and just the willingness to share time together. I know everyone is extremely busy and I'm just thrilled. So thank you for being here, and thank you all who are participating for spending some time in this evening to sort of get the latest and greatest from this group. And I will try to
Thank you, Holly.
Yeah, I'll try to get the resources there for you.
Thank you, Holly, so much. And lastly, my BFF for many, many years, Dr. Jim Schultz. Jim, if you could introduce yourself and add any of your own flavor of instructions before we transition to the panel as the guru who's going to manage all the incoming Q&A and facilitate some of the discussion.
Hi, I'm Jim Schultz. I'm family physician, chief medical officer at Neighborhood Healthcare. I'm on the faculty at UCSD and have residents hanging out with me every week. And I'm the question guy, so bring them on. I've got chats, I've got questions coming in. If I can't get to them, I'll write them down for next week or 2 weeks from now.
Thank you. Yeah, and that's a good reminder, by the way. Thank you, Jim. I should plug it. We have committed, and some of my staff behind the scenes may throw virtual things at me for what I'm about to say, but we have committed to at least doing 2 additional virtual town halls. We are going to take a little bit of a breather next week, but our next scheduled one, in case we lose you at the end, is on Wednesday evening at the same time, December 30th. And then also on Wednesday evening, January 6th in the new year. Depending on what's happening the night of January 6th, this is where the virtual things start flying. If the demand is there, we will consider extending it and doing some additional town halls as well. So thank you, Jim, for that reminder. While we have so many folks on the line in the midst of the meeting, we will not be together next week, but we will actually do one on December 30th and on January 6th. So with that, I want to turn the floor and the screen and everything over to Dr. Wilma Wooten, our public health officer, and Dr. I said it, Rob, see, naturally, and Dr. Rob Sills, our Medical Operations Center director, who works very closely with Dr. Wooten and has such a strategic role in the behind the scenes and front scenes of what's happening at the county. So Dr. Wooten, the microphone and the screen is your own. Thank you.
Thank you, Dr. Nick. Can everyone hear me? Yeah. Yes? Can you hear me, Dr. Nick? Okay, great.
Sorry.
So in the interest of time, and as Dr. Nick stated, I will only focus on the whole vaccination process, allocations, and distributions. So in the next slide, I just want to briefly go over roles and responsibilities from the CDC level to CDPH down to the county level. So as everyone should be aware, CDC allocates the vaccines to all of the states. And for the state of California, that is the California Department of Public Health. And then the California Department of Public Health announces when the COVID Ready portal is open. This is how providers and healthcare systems register to get their allocations of vaccines. Now, in some cases, our local staff, and many of you know Melissa Toon, can help facilitate enrollment or answer any questions, but the actual enrollment is the role of the healthcare entities on this COVID-ready portal. And so the healthcare systems include in this portal the number of vaccines that they want to get. That number is not determined by the county. The healthcare systems and various entities determine that. Then next, CDPH also works with local healthcare systems to determine or to, again, ensure that those numbers are enrolled in COVID ready and that the number of vaccines are allocated to, what numbers of vaccines are allocated to the regions throughout the state. They actually have the various numbers. For instance, when we talk about in phase 1A, for, say, for instance, acute care hospital workers or employees, they have stratified highest risk, high risk, medium, and low, and they have those numbers. They've determined those numbers. So they work with the local entities in knowing what those numbers are, and that also helps entities decide what allocations they need. And then the county allocates, and allocates is a strong word, but they basically allocates vaccines based on available supply to the COVID-ready enrollees. So going to the next slide, and that's with the exception of multi-county entities such as Kaiser or federal entities or the military or the pharmacy partnership programs, and the latter, that partnership program will be providing vaccination for long-term care facilities, staff, and their residents. And basically an example of this is, and then I'll give more details in a minute, but an example is that for the highest risk healthcare personnel, that number was 39,000, just over 39,000, and we got or received just over 28,000. So again, the initial allocation of that was basically based on what percentage that was of the overall. But in subsequent phases and tiers, we will also have guidance from our San Diego County COVID-19 Vaccine Advisory Committee. So moving on to the next slide. Actually, this slide also further talks about how CDC determines where the vaccines go. CDC works in collaboration with manufacturers, and it's going to vary from manufacturer to manufacturer. In the case of the Pfizer vaccinations, they were shipped directly to the various entities as identified in COVID ready. So for instance, in San Diego County, there were 3 what we call pre-positioning locations, UCSD, Radies, and the County of San Diego. The County of San Diego received, in addition to what we would provide to our psychiatric hospital, they received other supplies because some of the local hospitals didn't, at the time when these orders went in, did not have the capacity to store the vaccines. So I will actually go over that list in just a minute. But with the exception of 2 healthcare systems, everyone has now received directly received their vaccines. Actually, 2 will get theirs on the 18th, and then some of the hospital systems wanted us to hold on to the vaccine because they weren't quite ready yet. So there are 2 that fit in that category, and we will await their direction as to when to send the vaccines to them. But we received vaccines for 9 actually, including the psychiatric hospital, 9 different facilities. So 8 external facilities and our psychiatric hospital, which is only about 180 vaccines So again, going back to direct shipments, that's what happened in San Diego, those 3 pre-positioned locations, again, UCSD, Rades, and the county. Also, the federal government Ship Direct is working with pharmacy partnership programs, and CVS and Walgreens will be providing vaccinations to long-term care facilities. Also, the federal government gets their shipment directly, and there are others like tribal or multi-county entities such as Kaiser, as I stated before. And then also CDC approved, as I stated before, the COVID-ready enrolled entities or providers. And then CDPH identified the multi-county entities. And again, multi-county entities would include Kaiser, federal entities such as the military, and again, the pharmacy partnership program. And then the shipments that would go directly to the county of San Diego, and I've already talked about that and how we received shipments for 8 other external entities. But again, all of this information, the numbers are provided by the healthcare systems, not the county. And whatever is provided in that system, that's what the entity would eventually receive. So going on to the next slide. Now, as everyone should know that the National Academies of Science developed this phased approach to vaccines allocations for COVID-19 vaccines back in October, and they had 4 phases. The second phase was focused primarily on critical care workers. They moved that phase 2 into phase 1. It became phase 1B. Phase 1B became phase 1C. So now we're left with 3 phases. So phase 1A, which has a total of 3 sub-phases, and then phase 2, which previously was phase 3, and phase 3, which previously was phase 4. And the bottom line is now the 2 phases that, the latter 2 phases, 2 and 3, are really the general public, young adults, children, and also, if we go to this slide, phase 2 is now children and young adults 30 years of age and younger, and all other critical workers that were not identified in phase 1B. And then phase 3 is everyone else in the U.S. And people keep asking, when am I eligible? When am I eligible to be vaccinated? Again, in the general public, people with insurance would be vaccinated by their healthcare providers, and then the resources that the county has for locations where people can go obtain vaccinations, like we've done for influenza. We would leverage on the strength of our experience from influenza, and then add on additional locations like some of our testing sites that people are aware of. But it will be a different or separate from actual testing, but it would be at the same location. So right now the focus is on phase 1A, and phase 1A has been stratified by the state CDPH into tiers. So we have healthcare workers, long-term care facility staff, and residents. Those entities or healthcare professionals and residents make up, if we go to the next slide, the first dot point in tier 1. The first and second dot point in tier 1. And I talked about, I didn't yet, but paramedics and EMTs and others providing emergency medical services have been grouped into tier 1. But the other first responders, like policemen and firefighters, they are in tier, or actually they're in phase 1B. So again, only the paramedics, EMTs, and others that provide emergency medical services, and then dialysis centers are in tier 1. Tier 2 includes intermediate care for persons who need non-continuous nursing supervision and supportive care, home care and in-home supportive services, community health workers, including promotoras, public health field staff, not administrative staff, but field staff, and then primary care clinics, including our federally qualified health centers, rural health centers, correctional facility clinics, and urgent care clinics. Those are all in Tier 2. And Tier 3 includes other specialty clinics, laboratory workers, dental and oral health clinics, pharmacy staff, not working in settings at higher tiers, because there might be pharmacy staff that are in tiers 1 or 2. So that is the layout, and right now the state is going through step by step through the tiers in phase 1A. And right now we are focused on acute care, psychiatric facility hospitals. Keep in mind, we do not have a correctional facility hospital in San Diego, so that doesn't apply for us. So our primary focus is on acute care and psychiatric hospitals in San Diego. Going to the next slide, if we look at that first dot point in Tier 1 of Phase 1A, the number of healthcare personnel is almost 83,000 individuals. And everyone has been hearing that we received just over 28,000 doses. So knowing that we were not going to be getting all of the vaccines at the same time, this number, this almost 83,000 individuals, was further stratified by the state into those at highest risk, high risk, medium risk, and low risk individuals. And these are the numbers that are provided here. Again, this information is from the state. And so we're just working this week, given the vaccines that have been shipped to our hospitals. We are working on the highest risk individuals. There's 39,755 individuals in that group. We received vaccines to the number of 28,275, which is 72% of that. And so this is the first allocation that has been shipped directly to Rady, UCSD, and then the other 9, or rather 8 hospitals, their supplies of vaccines were shipped to the county because they did not have the capacity to store those vaccines at the time when they were expected. So the question many people ask is, for the 28,000, do we save half of that for the second dose? And the answer is no. The state we're told, has held back the appropriate number so that people can get their second dose. So we will wait for that at the time, 3 weeks from the vaccination point. So that's basically Tier 1, that first element or section of healthcare personnel. When it comes to the long-term care facilities, as I stated before, the federal government has partnered and contracted with CVS and Walgreens, and the plan is that they will provide vaccinations for long-term care facilities, staff, and residents. And I think certainly we'll take any questions. Just want to go to my last slide and just emphasize the fact that even with vaccinations, we are not disbanding what CDC refers to as the 3 W's: washing your hands, watching your distance, and wearing a face mask. These non-pharmaceutical interventions, we will need to continue these efforts, and we hope that as our medical healthcare partners, that you continue to convey these messages to your patients. Now, when it comes to individuals, if they do become ill, we want individuals to be tested. And then after their symptoms resolve, CDC is recommending that people who have developed COVID, if they are determined to be positive, to wait 90 days before they are vaccinated. But they are recommending that people even if they've contracted the illness, get vaccinated, but to wait at least 90 days. So I will end there, Dr. Nick, and turn it over to Rob.
Thank you, Dr. Wooten. I believe Sharon is going to do the slide advance for me. Great. First, next slide. We're going to talk about the Pfizer vaccine. Like Dr. Wooten said, 2 doses, 21 days apart. This requires ultra-low temperature storage, shipped directly from Pfizer. And the minimum storage allotment, the minimum allotment for the doses is 195. And in addition to getting the vaccine, everyone will receive an ancillary kit and a dry ice kit, and this is the first re-ice, and it'll all arrive the same day. The reason they did this is some of the facilities don't have ultra-low freezer capacity, so they will be able to use recharge the container with some more dry ice, and the dry ice comes with PPE that you need in order to handle the dry ice. Next. And it's packaged in specially made temperature thermal shippers, and it holds up to 5 trays about the size of Chicago deep dish pizza boxes. And the quantities are listed there. 1 vial is 5 doses, 1 tray, 195 vials, et cetera, et cetera. For the sake of time, I'm not going to read all this to you. I believe the slides will be available. So next. That's what the container looks like. Again, you have dry ice on the top and on all sides and on the bottom, and then you have those 5 pizza boxes in the middle. Next. Upon receipt of the Pfizer vaccine, we have to immediately inspect it. You can only have the shipper open for 5 minutes. Storage options, once you open it, is to store in the thermal shipper, so you re-ice it, or you take them out and you put the pizza boxes into an ultra-low temp freezer, or you can store it, you can put it immediately into a refrigerator where it will last. That's when the clock starts, and it'll last 5 days or up to 120 hours. Next. And you can re-ice within 24 hours of receipt. The recharge will hold for 5 days, and you can re-ice it up to 2 more times or get a total of 20 days at the ultra-low freezer level. Next. Again, that's a closer look of one of these containers. Next. So the vaccine requires diluent, and that's normal saline, and that's in the ancillary kit that's provided by the U.S. government. Ancillary supplies. The vaccine shelf life in the ultra-low temp freezer is about 6 months. And once you reconstitute it, it can be left at room temperature for 6 hours. So you have a 6-hour time window to vaccinate the population. Thaw times 3 hours in a fridge or 30 minutes at room temperature. Next. And the ancillary supplies, again, here's a kind of an inventory list. You get needles, syringes, prep pads, some surgical mask, etc. Next. You also get needles for mixing and syringes for mixing and the normal saline. So everything comes that you may need. Next. That's a picture of what the ancillary kit looks like. Next. The Moderna vaccine, that's going to be a little bit different. 2 doses, 28 days apart, requires frozen storage. And you notice, those of you that are used to these frozen vaccines, it's a narrower temperature range than usual. These will be coming directly from McKesson, and ancillary supplies will be shipped from the U.S. government. All the providers that are registered in the COVID Ready website will receive their allocation directly from McKesson. Next. The McKesson minimum order is 100 doses. So that's why a lot of you will probably be receiving the Moderna if you're not in a large hospital. Again, there's the shipping and storage with thaw times. Next. Again, up to 12 hours at room temperature, and it must be used within 6 hours of the first entry or puncture. Next. Now for the monoclonal antibody therapeutics. When this originally came out, it was intended for acute care hospitals. CDPH has started allocating these to skilled nursing facilities and other federally qualified healthcare centers that have the needed pharmacy support, because these have to be mixed and some of them are complicated. And the SNFs need to have either a pharmacy associated with it or a hospital that oversees it. Next. The way we send out the allocation, because obviously we don't have enough for everybody, is a proportional allocation based on the number of cases that either they'll see in a week or they have in their hospital. Next. All this is in an emergency use authorization, and I have white papers that show who's eligible and who isn't. Next. Again, some of the, these are the high-risk people that are eligible. Next. And next. Again, you have to meet this criteria in order to be a candidate per EAU. Next. And it's not authorized for use in patients who are already hospitalized or require oxygen therapy. Next. And the other therapeutic are not authorized, again, for patients who are hospitalized due to COVID or require oxygen therapy due to COVID. Next. And benefits have not been observed in patients who have been hospitalized because of COVID. Next. It's to be administered for the treatment of mild to moderate COVID in adults and pediatric patients. Next. And those who have a high risk as defined by the criteria there. Again, I have the white papers if anyone is interested. Next. And next. The allocations that we receive each week are given to us by CDPH, and the MOC has 24 hours to submit the allocation for the county. And these allocations will be shipped directly to the pharmacies associated with the facilities that we allocate for. So last week was the first week that we sent allocations to non-acute care facilities, and I'm hoping to expand that with this week's allocation. So there are some number of you on the phone that I've been in contact with in order to get the amounts of the doses that you would be running through in a week, so that we can make sure we can get that. If anyone has specific questions or wants to know more, hopefully my email address will be in the chat for everyone to bomb my emails with, but I will get information to you as quickly as possible. And if you have the pharmacies that can handle the mixing and the infusion at your site, then I'll do everything I can to get some doses out to you. That concludes my slides, I believe. Next. Excellent, thank you.
And Dr. Nick, I just have one last comment. As everyone probably has reviewed, our county website, for COVID-19 daily slides. So for instance, the slides we reported out today or used today in our briefing are on the website. And also today we launched the vaccine web page or web presence on the COVID-19 website. So that was done today. So you can go to the website and look for information as it relates to the COVID-19 vaccine. And also on every Tuesday, we issue the COVID Watch, and that also is found on the web page as well. It's actually found at the bottom of the page, of the data page that you click on with the stick pin in it when you go to the COVID-19 website. So thank you.
Thank you, and thank you so very much, Dr. Wooten and Rob, and can't thank you enough for comprehensively covering so much material. I know there's a lot of questions. Just for the playful record, I will say I, for the first time in my life, am not calling the therapeutics by their name, but I call it the Eli Lilly and the Regeneron, because I can't even say them right. So no worries there. But if I could, I will remind everybody, please, besides Dr. Wooten and Rob, we have Dr. Little, we have Dr. Hood, we have Dr. Ramers, Dr. McDonald is lurking as needed. And so what we'd like to do now is use the rest of our time for Q&A. I know there is a lot of it, and this is where I lean on Dr. Schultz. Jim, to take it from here, please. Thank you.
Yeah, a lot of questions. I think they kind of fall into two categories. I'll start with the first category is more of a clinical vaccine category. One, there were some questions about the Bell's palsy popping up in some of the clinical trial data. There's another question about, and I think we have a couple of people on here that can answer these questions, so I'll just throw this group out. The next question was, can people who once they're vaccinated, can they still spread COVID? What are the recommendations for children? And is there really a sixth dose in those Pfizer vials?
All right, thank you, Jim. Just to give Dr. Wooten and Rob a little breather, and knowing that we have Dr. Little and Dr. Ramers online, Susan, I'd like to first turn to you and see if you have comments, and then I'll turn it over to Christian.
Sure. The Bell's palsy question. So sort of amazingly, both the Pfizer and the Moderna study had 4 cases of Bell's palsy. I think I may have this backwards, but I think Pfizer, they were all in the vaccine arm. And I think in the Moderna, there were 3 in the vaccine and 1 in the placebo. And the bottom line was, I think the comment was that the rate at which these cases were observed was not above that is typically observed in the general population. So there was a slight imbalance between the vaccine and the placebo arm, but the rate was that that is generally seen in the population. So at present, again, these are, early cuts of the data. There has not been an attribution of Bell's palsy as a risk, but certainly that will be followed going forward.
Thank you. Christian.
Yeah, that's exactly right, Susan. 4 in the Pfizer arm, 0 in their placebo, 3 in the Moderna, 1 in their placebo. If you calculate the rates, that's going to be 20 to 21 per 100,000. And if you look it up on UpToDate, the background range is 13 to 34. So it's actually right in the range of what you would expect for the general population. I'd like to just make a comment about phase 4 and ongoing post-marketing surveillance. The CDC has the Vaccine Adverse Event Reporting System, or VAERS, where anybody, a vaccine recipient or a provider, can report anything. It's a passive system, so it actually just sort of waits for people to report stuff. But they're doing more active surveillance with a cell phone app called vSafe that they're encouraging all vaccinators to actually tell people to download. That'll remind people with a text message daily for 6 days, and I think weekly after that for 6 weeks, where everybody can report what they want. And look, nobody's kidding themselves that when you vaccinate 40 million people, you might have more rare events than 40,000 people. So, but I think reviewing all of the FDA data that was presented on Pfizer, the Moderna data is now available. I'll put the links actually in the chat if you like. These are really quite safe vaccines. There is some reactogenicity we can talk about later if you like, but really nothing that was a serious adverse event.
Jim, in his rapid fire, also asked about the utilization in children. Susan, do you want to start with that and just maybe handle that one?
Sure. I mean, the Pfizer vaccine, there was some disagreement. The only reason that the EUA, the emergency use authorization vote, was not unanimous for the Pfizer vaccine was because some of the pediatricians felt that there was not yet enough data to endorse the use of the Pfizer vaccine in people under the age of 18. However, in the end, it was approved for use in people age 16 and older. I did do a quick search. I cannot yet find, and others who may have seen something, an official statement from, American Academy of Pediatrics or any other, pediatric group officially sort of making a statement about it. But in general, yes, the vaccine is, as Dr. Raymer said, it's incredibly safe. It's approved for adolescents 16 and adults 16 and older. Again, these are these are safe vaccines. The side effects, the reactogenicity for the first 48 hours, more significant and more prominent in younger people.
Thank you. Yeah, and I even had interaction today with folks who got it, who are frontline nurses and physicians in various facilities, and that was definitely the case. I will also add, in terms of the safety profile, and again, not to uncork another whole can of considerations here, but I'm a little bit shocked with some of the anecdotal and even survey data that I've seen in terms of reluctance of even critical care nursing and other staff related to having the vaccines themselves. Susan, I'll just pick on you one more time to make a comment about the whole safety thing internally, and then I'll turn it to Jim.
Yeah, I have
And
to
I have
say,
a comment, Dr. Nick.
Okay.
I have to
Go
say,
ahead,
I've heard some of the same concerns by healthcare personnel, by healthcare providers, and I've been surprised. You know, compared to many of the other vaccines we've seen, these are, again, we have early data, but these are quite safe, I think, vaccines. Given everything we know about mRNA vaccines and their potential to cause toxicity, they cause reactogenicity. I don't know how to say that. So the first 48 hours are potentially not pleasant, but the risk benefit, COVID, 48 hours of not feeling well. And I think some of the sort of symptom profile of the first 48 hours have scared people off. But I also think there's been a lot of, political unrest that has scared people off of these. And again, I just want to throw out the way in which these vaccines are made. I just think there's very low risk for toxicity for this particular platform of vaccines.
Thank you. Dr. Wooten. Are you there, Dr. Wooten?
Yes, I'm here. I just wanted to make a comment about the children in the clinical trials. On the CDC call this past weekend, they noted that there was 163 children, 16 and 17 years of age, that were included in the clinical trial. So just wanted to share that with people.
Thank you. Thank you. Jim.
Yeah, one final question on the side effects of the vaccine has to do with the reports of anaphylaxis. Is this something we should be concerned about? How long do we need to watch people afterwards? Do we need to make sure we have Epi and Benadryl in our emergency kits, et cetera, et cetera?
I will turn it to Susan, our academician, to handle that. And then Rodney, I'll come to you to see if you have any general comments on what we've talked about to this point before we quote unquote move on other topics.
I think the formal recommendations are that I think, unfortunately, I think the UK overreacted with the recommendation that no one with allergy should take these vaccines. The CDC's recommendation is that people with allergy to components of the vaccine, with serious allergic reactions to components of the vaccine, should not take these vaccines. But otherwise, people with serious allergic reactions to other things, bees, should not avoid taking these vaccines. They should be observed for longer, 30 minutes as opposed to 15, and should certainly tell the people who are administering the vaccines that they have a history of serious allergic reactions to something else, peanut butter, bees, whatever it is. My personal thought is if you have an EpiPen, bring it. But I think in general, the recommendation is those individuals with serious allergic reactions to things that are unrelated to the constituents of the vaccine should feel comfortable going forward and receiving the vaccine. They will be watched more closely.
Thank you, Susan. Rodney or Christian, before I go to Rodney, a quick one from you. Christian, go ahead.
Just if you haven't memorized the components of the vaccine, there's mRNA in it, there's a bunch of lipids, there's sodium chloride, potassium chloride, sodium phosphate, sucrose, and then in the lipids is polyethylene polyethylene glycol. That's the only one that may
Right.
be in common use. Miralax, pegylated interferon, pegylated chemotherapy agents. If someone has anaphylaxis to any of those things, then that would be a consideration. But otherwise, I think you can just be cautious.
Rodney?
Yeah, thank you, Nick. Let me tell you from the beginning, I've been involved in evaluating these vaccines, the various groups I've been on. I've actually had the privilege of meeting with Pfizer, Moderna, Johnson & Johnson, and AstraZeneca. Why am I involved? I'm not infectious disease. I'm not a virologist. Actually, it's the whole equity lens. And California in this country is a very diverse country. If we look at the populations that we're talking about getting vaccinated, some of the highest populations that are infected, some of the highest death rates, they also are the populations that are most reluctant to receive the vaccine. And so how do we deal with that? So from a scientific point of view, I've been very impressed that the Pfizer vaccine, I will agree, is extremely safe. Part of my contribution to the California group that was appointed by the governor was trying to bring the equity lens. And I was quite impressed with the Pfizer vaccine. It was tested in 9 different countries, including South Africa and Brazil. It had 6% Asian in the US, 5% overall, 10% Black in overall, as well as in the United States. Hispanic Latinx, 13% in the United States, 26% overall, only 1% Native American. And I think the most impressive thing was the 95% effectiveness that was seen in all race, ethnicity groups, as well as age and gender. Now, it was only looked at for 2 to 3 months, so clearly the FDA and Pfizer needs to continue to monitor that as this vaccine is ruled out. I was one of the paranoid physicians 6 months ago when one of my patients said, "Doc, are you going to take this vaccine that the current administration is talking about?" And I said, "I'm not really sure I will." Many of my patients were reluctant. The more investigation I have done, I'm happy to say that the Pfizer vaccine and what I'm learning about the Moderna vaccine is a very safe vaccine. As a matter of fact, the science behind these are very interesting, and I think a lot of promise for the future. So I think the message we need to give is that this vaccine is safe for all populations. And I think there are 3 groups of patients: those that are willing to take the vaccine, they may need to get access. And then there is another group for holistic reasons or distrust reasons that will not. But there's a middle group that are reluctant to take it, that with scientific data and education and outreach, I think we can improve those numbers.
Thank you, Rodney. I really appreciate the perspective and your advocacy, obviously, and keeping us both accountable, and your transparency about your own experience. Dr. Wooten, I think I saw your hand up. Did you have something else to say before I go to Jim?
Yes, Dr. Nick. I just wanted to share regarding the anaphylaxis question. There was a lot of discussion on the CDC call over the weekend, and what they recommended for right now until more is known is that anyone who has had an anaphylaxis response to injectables should not right now get it. They are asking people to hold off. But if you have an allergy to any foods, they should go on and get the vaccine. They should be monitored for 30 minutes, but individuals that have no history of allergies 15 minutes is what the monitoring time period is recommended. So just wanted to share that.
Excellent. Thank you. Thank you. Jim?
Yeah, a lot of questions about how does X, Y, or Z get access to the vaccine. So a small private practice, a specialty office, a surgery center, a nursing school that may not be able to register on COVID ready also may not have the resources to get a minus 80 degree refrigerator. How do those folks get vaccines? And then for Rodney, how do we make sure that they're not all going to Scripps and Sharp and they get down into Rodney's neighborhood too?
Thank you, Jim. I think in terms of some of the logistics, you know, and obviously, again, there's a lot there. You lumped a lot of things. Rob and Dr. Wooten, maybe I'll defer that to you, and then we'll go to Rodney.
So for, again, we are going through the phases and the tiers within the phases. And when people are, when it's their turn, the communications will be made with the various entities. Staff is spending an enormous amount of time and planning with the state and trying to figure this out. And while all of the logistics and details are not currently developed, but as we approach those different elements within each tier, that population will be contacted. So when it's their turn, people will know.
Well, and let me ask a follow-up, because Rob, for example, is it dependent with what Dr. Wooten just said of the folks registering on COVID ready to get that notification, or will those notifications of quote unquote when it's the right time, will that happen through other means? Rob, could you deal with that?
Come from the state, yeah.
Yeah, the confirmation will come from the state, and you know they have the whole directory, and they know, hey, we need to queue this next group up, but then we need to queue the next group up, and they're going to go through phase 1A before they go to phase 1B,
yeah,
and then 1C, and then all the sub tiers and everything. In regards to the question, well, should I go the COVID ready because I don't have an ultra low freezer? There are 6 vaccines in the pipeline, and the first 2, Pfizer's the only one that I know of that has the negative 80 degrees. So the Moderna is just a freezer, and the other ones I haven't read all the specifics about it. So they will ship to the providers based on the how they are in the database, the COVID ready database.
And one other thing, though nobody's asked it explicitly, I'll just either state, and Dr. Wooten can correct me. Everybody's, well, then how much of XYZ vaccine are we going to get depending on the pipeline and all of that? We are not reluctant or not holding anything back. As soon as we know, we will share that. Anything else on that, Dr. Wooten, related to the pipeline that Rob referenced?
The providers are going to tell the state. When the state reaches out to the providers, inquiries will be made, and the providers will tell the state. And once that's once they are enrolled in the ready COVID ready, then vaccines will be shipped directly to those entities.
Yeah, and so we're starting to get notifications. We'll probably get notifications today, tomorrow, the number of Pfizer vaccines that we'll be receiving next week. This next shipment, they're going to take off the top all the allocations that need to go out to long-term care facilities through the commercial pharmacies. And then what's left will be sent out to the different counties, again, based on the numbers in the database, in the COVID-ready database. And then the Moderna vaccine, the thinking is that it's probably going to follow exactly like Pfizer. It goes for EUA, it gets the vote on Friday. If it's approved, we'll probably get it shipped, early next week. But again, they're going to go out in increments of 100 and go directly to the 1A, Tier 1, and possibly Tier 2 if there's enough vaccine.
And also keep in mind that over the weekend, ACIP is also meeting to make the appropriate recommendations for the Moderna. So this 1-2 step process has to happen for each vaccine. That is first the advisory committee, the FDA's advisory committee meets, and then the FDA has to approve it. And once the FDA approves it, then CDC works with the manufacturers to get it shipped out. So, and that only occurs also after ACIP approves it to CDC. So there are a lot of steps involved, but basically the advisory committee to the FDA, then the FDA, and then the advisory committee to CDC, which is ACIP, and then CDC, Redfield says good to go, and then that's when the vaccines are shipped out.
Thank you. Rodney, and obviously I'm not saying it for you, but everybody, we're going to do our best to honor the time, but there was quickly a question about that Jim asked related to access and so forth, if you could handle that.
Okay, I'm going to do two. One, they asked about private docs, and let me thank President Holly Yang, who brought to me and others. I actually serve on the as tri-chair, and so the private docs and specialty docs who are asking how they're going to get the vaccine. Number one, remember this phase 1A. Right now, we're in this 3 tiers. Tier 1 is where we are now. For the private docs and for the federally qualified health centers, they're in tier 2. For the specialty clinics, they're in tier 3. How do we plan on dealing with that? We're going to put together what we call a subcommittee of solo practices independent physicians. And I'd first like to give a shout out to all of the medical directors or anybody who's associated with an independent IPA, the scripts, the shops, and whatnot. I want you to reach out to me and or Holly, because we want to get representatives from those IPAs as part of the subcommittee. Because in order to get the vaccine, you're going to have to register. Have to register with the state. And I think the most efficient way to do that is through the IPA that you're associated with. So you'll be hearing more about that. Please share my email and send it to Holly. She'll get it to me, because I'm looking for names of individuals that can be part of the subcommittee. Number two, you asked about how are we going to vaccinate? Well, the state, the governor, and here in the county has implemented what we call the health equity matrix. And they're using a healthy index based upon 8 criteria. Don't ask me what they all are, but one of them is by zip codes, by the socioeconomic status in that area, what the rates of sickness are in that area. So there's about 8. And so the most underserved and high-risk areas will get a health equity matrix number. And based upon that, we hope to distribute and focus in an equitable way rather than an equal way. So if Southeast San Diego has a higher index than La Jolla, we want to prioritize vaccinations or whatnot in that area. So briefly, that is the strategy we're going to use in trying to implement vaccinations in San Diego County.
Thank you, Rodney. And realizing very much, thank you. Realizing how many questions there still are, I'm the guilty one. Blame me, but I just made a decision. We're going to extend it for another 15 minutes. And Jim, you're going to do the savant job of prioritizing the questions. If any of the panelists, in respect to my colleagues, are not able to stay on an extra 15, those who are will handle it. Jim.
Just some further clarification. If you're not in an institutional setting, if you're not in a big group and not in an IPA, how do those doctors get vaccines for themselves and their staff? Do they just go to their own physicians? A lot of them want to get vaccinated early. because they're being exposed to COVID patients in their practice? Is there a channel for them to, can they sign up with COVID Ready, or is everybody eligible to sign up, or what's the alternative channel?
I'm thinking the logistics of that. Rob, do you want to answer that? Again, is it a matter of COVID Ready prioritization?
Yes, it is. You know,
Rob, we lost your audio. I think.
Okay, I had a great answer. Now I just have to remember what it was. So
now you're back.
You're right. It is COVID Ready for their practice, and they will be notified when, you know, again, when they're in that tiered structure. But if someone has a primary care provider that's at a larger system, you know, they'll be notified when they meet the qualifications, you know, of the categories, and, you know, are you over 65, et cetera, and they'll be notified to come in to get their vaccine.
Thank you. Look, if there are still lingering questions on this issue, you know, send them to us directly. We will follow up. One thing I do want to say publicly, please, especially to all of my clinician colleagues, there are two things that we do not want, please, under no circumstance, for you to be sending patients to the emergency room for. It is not to get a vaccine, and it is not to get a routine test. We don't have time to get into it tonight, but our emergency rooms are being hammered. We do not have the capacity to even remotely, and I realize many of them are coming on their own, but even remotely be having people walking in looking for quote unquote routine testing and vaccinations. Jim, I'll turn it back to you.
We have a question about how the firefighters and EMS, like who's going to actually be doing the vaccinations of those? Is that a public health effort? Are they going to vaccinate themselves? Is there some health system that's taking responsibility for that?
Yeah, I think so. I'll take a first stab at that. We're working with CAL FIRE and the other fire agencies to have their paramedics do that for, you know, vaccinate themselves, as well as the providers that oversee, you know, each of those fire companies and fire departments.
Thank you. Do any of the other panelists want to add to anything to that? Next question, Jim.
There's a question about if the practice doesn't participate in SDIR, can they still receive the COVID vaccine and administer it?
Absolutely.
I believe so, but we really would appreciate it if everyone would put in their doses in SDIR.
Yeah, and that I mean, I don't. Let me say this, and again, I could be erroneous. We really, for the sake of tracking and data and everything, you know, if you have a problem with accessing SDIR or something like that, let us know. But for fidelity, and Dr. Wooten, I'll come to you next. That is part of our regional process that I think is very strategic. Dr. Wooten.
Yeah, I was just going to say, for those that are not already registered in SDIR, then we would have to do it manually. So we have forms that we can provide. Those forms will be filled out and then provided to our immunization program so our staff could input that information.
Thank you, Dr. Wooten. Jim.
Yeah, I think I asked too many questions at one time and one got skipped. Once vaccinated, can we still spread the virus? And I think the corollary question is, how long are we going to have to wear these darn masks?
Well,
so I'll start first.
Let me pile on, and I'm going to have Dr. Wooten start, and then Christian. The issue of the implications of the vaccines and the masking and all of that. Do we know yet, in terms of the vaccine, is it protect individuals from being infectious? Timeline of potentially being at risk for reinfection, all of those issues. We'll start with Dr. Wooten and then Christian.
So in terms of until people are going to have to continue to wear masks and exercise all of the non-pharmaceutical interventions, those 4 W's, or 3 W's, sorry, 3 W's, until we can achieve herd immunity. We do not know if individuals can transmit the disease or spread it to someone else. CDC basically this weekend stated that that was not part of the clinical trials. So the evidence or the word on that, we just don't know just yet until additional research is conducted.
Thank you, Dr. Wooten.
I'll add that it's coming. So we can't say that now. There was a hint in some of the Moderna stuff that there may be. Plausibly, it makes sense that probably there would be reduced, but we can't really say it yet until the evidence is out there. But clearly there are going to be sub-analyses and further studies of vaccinated individuals with swabs in their nose and their mouth that will come out, I anticipate, in the next 3 months.
Thank you. And because I think it's such an important issue, despite all the questions, since I'm keeping you after school, Susan, anything you want to add about, the yet to be determined follow-up from vaccinations and so forth?
No, I think everybody hit the highlights. Please do not take your masks off.
Thank you. Jim?
Just a plea, there's 2 communication requests. One is some specific communication out, and maybe the medical society can help with this, to all of the doctors about how they sign up with COVID Ready and get the vaccines for their practice, and how the notification of when they're going to be able to do that is going to happen and from whom. And then secondly, how are we going to, what are the efforts going to be around communicating to patients about the vaccine and its safety and its importance?
Yeah, related to that, maybe Rodney, let me give Wilma a chance to catch her breath. You start with that, and then we'll go to Dr. Wooten regarding further public messaging.
Yeah, I would say to all the physicians, don't wait for your patient to ask the question because they may be afraid to ask. But there is a lot of vaccine hesitancy out there, and there are certain ethnic groups that are more hesitant than others. African Americans lead the group. So I would upfront address that question, that this vaccine has been found safe in all ethnic groups for Blacks, Hispanics, et cetera. It's been evaluated in populations in Africa, in Brazil, et cetera. So I think in education of your patients, don't assume that everybody thinks the same. I would bring that up front in your education.
Thank you. Dr. Wooten, anything else on the public education plans we have up our sleeves?
Well, there is a public education campaign that is in development. It will be vetted with all of our various partners, including the advisory committee. So that's coming down the pike.
Perfect.
Yeah. And also, Rob is going to share with you, but people need to be invited from the state.
Yeah, so for the COVID Ready database or website, the providers will get an invitation from CDPH when it's their time based on their practice and tier structure.
Yeah.
Interesting. Okay, thank you. Jim, next question.
I want to move over to the monoclonal antibody since we spent all the time on the vaccine. A couple of questions there. When can practices get monoclonal antibody to give to their patients? Or where can we send our patients to get this administered?
So those are some great questions. We cannot allocate doses to anyone that doesn't have a pharmacy to do the mixing and infusion capabilities. Right now, CDPH and the CDC are really focusing on skilled nursing facilities and urgent cares or community clinics or federally qualified healthcare centers and dialysis centers. But we do recognize that the dialysis centers, we don't want a newly confirmed COVID patients going into a dialysis center where some cancer patients are getting their treatment. So away from that, I know some of the hospitals have set up ambulatory dialysis centers just for this. But again, private practice, that's not on the list from CDPH or the CDC that's been given to me to sign up on as of this day.
Thank you. Christian, I'd like you to make a comment about this as well. But one thing I'm going to editorialize, and this is not critical, but there's already been, some press, not locally, but nationally, about underutilization. And I think we are hitting the perfect storm in terms of, emergency room impactions, the qualifications for pharmacy and this, that, and the other thing. So, I'm still hopeful that we're going to come up with some potential regional strategies to enhance access. But Christian, I see you unmuted. Make a comment as well, please.
Yeah, let me provide a little background here. We're now a month into monoclonals being distributed, and we can look back and say, well, this was rolled out a little bit quickly, I would say, and maybe not in the best way to avoid exacerbating inequities. The people I know at HHS and Operation Warp Speed are taking full accountability for that, and they requested an ethical consultation with the National Academy of Sciences, which has been occurring today and will occur tomorrow. I'll put the link in there as well, to try to help them think about equitable distribution of monoclonals, because they just pushed it out through the same channels that remdesivir went out to, because it was easy and it was quick, and they pushed out thousands of doses. I think there's been 200,000 doses of the bamlanivimab and almost 100,000 of the Regeneron product. They're rethinking things and thinking, wow, we might make things worse by just pushing these to hospitals, and then how is that going to get into the neighborhoods that really need it? So they're actually starting these things. Again, the naming is not very great, but it's called SPEED, S-P-E-E-D, which is an initiative to directly federally allocate doses of monoclonals to nursing homes, assisted living facilities, long-term care pharmacies, and then they're going to do some pilots coming up later to FQHCs, correctional facilities, and dialysis centers. So there's a lot of discussion about this, it was done a little too quickly. It's a precious resource. Lots of discussion on a national level. In fact, there's a 5-part mini-series where we're all talking about all these diverse settings that are doing it. How are they deciding the most high-yield patients to give it to? But to answer the direct question, I don't know how you get your patient to get monoclonals, because it was pushed out to the hospitals and they're making each their own rules. Rob can tell, I think I counted on your emails, Rob, maybe 1,600 doses of bamlanivimab that have been distributed out in San Diego, 500 of the Regeneron product spread throughout the hospitals in the area.
Yeah, that is correct. Just sitting here, I received the email of the next allocation, so I'm going to be reaching out to, again, it's going to go heavy non-hospital this time, because we've gotten about a week with the community clinics and the family health centers and FQHCs, and SNFs, to get all the stuff that they need ready to get to me so I can submit it. But the allocation, we're shifting away from the acute cares as quickly as I can.
All right, thank you. And, I think I would like to just quickly say, we've got some spaces that are being underutilized and other things like that. I am hopeful that as the supply, if you would, and supply chain of monoclonals increases, that there may be some other opportunities for us to come together on a regional basis to strategize on how we can optimize accessibility to them. So having said that, and having already extended the time, I'm not going to do it any further. Maybe we need to consider the next one being a couple hours. We'll internally deliberate on that. A big thank you. I'm not going to go through individuals, but a big thank you to all of our panelists for their input and wisdom and availability and just everything for tonight. Thank you to Jim. Thank you to the staff behind the scenes. May you all enjoy your holiday celebrations despite everything that is happening, and anything that we can do at the county to be a resource. I know the Medical Society would feel the same way with me saying this. We are a team that is united in the midst of what we are facing, and will be facing, and we are prepared. We've been at this for 9 months. I know there are a lot of you that are exhausted and already tired, and it's the worst possible time of year for us to be hitting the timing that we are. And I'll come to you, Dr. Wooten, in a second, but please, but please know that we are ready, we are prepared, we are in this together, and we are united in our efforts. So we are San Diego. We are eager and willing to stand with you and be a resource to you. And with that, blessings to your holiday celebrations. Thanks to all. A reminder to the panelists who are able, even though we're already running late, please linger. And to the rest of you, thank you very, very much for joining us this evening. We really appreciate it. Happy holidays.